welcome and invite, and good morning to everybody. So there's an increasing frequency of food hypersensitivity in the irritable bowel syndrome patients. And quite often, the more severe their symptoms, the more number of foods that they are blaming. And regardless, many of these patients are unable to accurately identify the presumed offending food when re-challenged in a double-blind manner. Regardless of this, the majority of these patients will still institute dietary changes and will do so to an extent that compromises their nutrition. So when it comes to trying to understand what could be these foods that are triggering these symptoms, and when we focus in IBS, we're talking about abdominal pain and bloating predominantly, we know that these symptoms are largely dictated by what is made up of the luminal volume, being that relates to the luminal distension. And we know that this distension is made up by or related to what's the solids, so what we are eating, gases being via fermentation or what we are swallowing, and fluid components being osmotic material. So therefore, targets for dietary therapy could be a group of carbohydrates which are poorly absorbed, rapidly fermented, and osmotically active. And this is what we focus on when we look at the FODMAP group. For those of you who don't know, FODMAPS is an acronym that stands for Fermentable Oligosaccharides, where we focus on the fructans being found in high amounts in foods such as wheat and rye and onion and garlic, the galacto-oligosaccharides, which are found in high amounts in legumes, the disaccharide, lactose, which is obviously found in dairy foods, the monosaccharide, where we focus on fructose in excess of glucose, found in many fruits such as apples, pears, mango, watermelon, and honey. And the polyols, which we focus on, are sorbitol and mannitol, found in stone fruits, but also used as an artificial sweetener in some food products. The FODMAP term and the research has really only become in the last 10 years. And we're seeing that the FODMAP popularity is really increasing. I just got this from the Google search trends, and you can see that particularly since 2013, that the FODMAPs as a term is being searched for quite rapidly. When we look at where these people are searching it for, many people are searching for FODMAP information, particularly from Australia, which is understandable, seeing though that is where a lot of the evidence first came about. So all of the evidence that has been around the low FODMAP diet has focused predominantly on understanding two different types of mechanism. The first mechanism that I'm going to tell you about is the small intestinal water. So this first study, which was done by the Monash University group, in 10 volunteers who had an end ileostomy, after having a low FODMAP or a high FODMAP diet for 4 weeks, found that with the low FODMAP diet, that there was a significant reduction in their daytime effluent, and that these patients also felt that they, on their a scale of how happy or satisfied they were with their effluent consistency, that they were much happier and satisfied with it on the low FODMAP diet. There's been quite a number of really nice, elegant studies coming out from the Nottingham group, further showing and using small bowel MRI to show us that the osmotic activity of these FODMAPs as well. So this first study, which was published in 2010, showed us that mannitol is responsible and can rapidly increase the amount of small bowel intestinal water. Then another study, which was published by the same group in 2014, further showed us that fructose, being an osmotically active monomer, clearly there has most of its activity for osmotic activity and increases the small intestinal water content. They also gave these 16 healthy controls a glucose and fructose drink, and you can see that visually that there is not as much water there, and that is due to the transporter mechanism behind glucose and fructose. And they also gave their participants an inulin drink as well. The next key mechanism that we look at when we understand the mechanism behind FODMAPs is the increased gas production. This was one of the first key studies to highlight and understand or point out this. So this study was conducted in 15 healthy controls and 15 IBS patients, and they provided all of their food to their participants for 2 days of either a low FODMAP and a high FODMAP diet. And this is the breath hydrogen over the course of that second day, and you can clearly see that the high FODMAP arm was responsible for an increased amount of breath hydrogen. And it was the IBS patients there with the dotted line at the top that had the more hydrogen being produced. Then there was this study published that was in Gut last year, which showed us, and this diagram shows you the area under the curve for the 5 hours of a breath hydrogen test after a lactulose drink test. And they followed a low FODMAP or high FODMAP arm for 21 days each. And what this shows you is that there might be some type of shift in the colonic fermentation pattern occurring, in that the same patients having the same drink in the same test, but after following a different diet, can have a different breath hydrogen response. The same study that I showed to you with the small bowel water content, also where they did the drink tests of the 4 different challenges, they also were able to quantify and estimate the colonic gas volume using that small bowel MRI. And what they found here, the green line being the fructans or inulin, which is a fructan, after having 40 grams of the fructan drink, that there was a rapid increase, or not a rapid, but there was a large increase in the colonic gas being produced, particularly for the fructans drink in comparison to the other FODMAPs. And what this highlights to us is that each of the FODMAPs acts slightly different. The same group went on to publish this study earlier this year, and what they did was they now recruited not only healthy volunteers but also IBS patients, and again gave them drinks of either inulin, fructose or glucose. And if you first focus on these 4 panels, you can see that the same response occurs in the IBS patients as it does in the healthy volunteers. So that colonic volume is being increased for the fructan or the inulin drink, and the small bowel water content is being increased for the fructose drink. Then when you look at this panel here for the symptom intensity, you can clearly see that the healthy volunteers reported no symptoms, whereas the IBS patients reported symptoms. And this really highlighted to us that the same physiological response occurs to the FODMAPs, and that it's more likely to be our hypersensitivity occurring to what's occurring to the FODMAP effects that is related to these symptoms. And this was a really nice key study because previously we thought, or we hypothesized, that the gas being produced and the water being induced or brought down into the colon was occurring at a larger amount for the patient group. So as I said, the low FODMAP diet as an approach to helping treat IBS is relatively new. However, in the last few years, there's been a really nice number of well-conducted randomised controlled trials, and not just from Australia, but from the UK and from the United States and from Europe as well. So this is a snapshot of some of the key RCTs that are now existing. I will walk you through a couple of these now, but what I'd like you to focus on here is that there is a variety of things that are being used in the controlled dietary trials, but also what they're using in the comparative diets. So whether it's a low FODMAP diet versus a high FODMAP diet, whether they are comparing it versus traditional IBS dietary advice, whether they're using hypnotherapy as a comparative as well. The other thing to look at here is how long they're using the intervention phase for. And the intervention phase here, you can see, is no longer than 6 weeks for most of them. Because there has been this number of RCTs now published, we have, in the last few years, some really nice systematic reviews which have been published. We also now have one meta-analysis which was published last year, and this meta-analysis highlighted and confirmed to us that there is good evidence to show that the low FODMAP diet can reduce particularly gut pain and distension and overall gastrointestinal symptoms. So this first study that I'm going to walk you through was published by the Monash University group in Melbourne. They recruited 30 patients with IBS, and the IBS patients that they recruited were of all different subtypes, and they used 8 healthy controls. What they did was they provided all of their food to their patient or to their participants for 21 days, and they based this, or they called this amount, which was the higher FODMAP arm, a typical Australian diet based on previous evidence. And what you can see here, the solid line being the high FODMAP arm, that there was symptoms being clearly and significantly induced and within the first 7 days of the diet, and that this then plateaued out across the 21-day period. For the healthy controls, they had no symptoms induced, which was the first time that had been done or shown, because in the first few studies behind the FODMAP diet, they had been using a really, really large amount of FODMAPs as their intervention. The next study that I'm going to show you is by the King's College group in London. So this was a randomised placebo-controlled single-blind study using dietary advice. So how we would in more of a clinical setting. So they recruited 104 patients and taught them all either a low FODMAP diet or gave them sham advice for 4 weeks. And what you can see here is that there was significant improvement on the IBS symptom severity scores for the low FODMAP diet, and also for each of the individual symptoms as well. The next comparative studies that I'm going to show to you is studies that used dietary advice and used the low FODMAP versus what is referred to as the standard dietary guidelines for IBS. Now, these standard dietary guidelines for IBS are based on the NICE guidelines, or the British Dietetic Association, where key things that come under these guidelines include telling your patient to try and follow small, frequent meals, limit your caffeine and alcohol, restrict your intake of fatty or spicy food, and just try and eat in a relaxed manner. And only eat when you're not too over full. Part of the other foods that they also restrict as part of the NICE guidelines do include onion and garlic, which are some of the FODMAPs, so there is a slight overlap there. So this study, the first study that I'm going to show to you was conducted by our chair group in Sweden, in Gothenburg. So they recruited 38 patients versus 37 patients on the low FODMAP versus the traditional IBS dietary advice, and they were asked to follow that for 4 weeks. And what you can see here is that there was clearly no differences between the two diets. However, there was a significant clinical response in both arms. So there was a 50% clinical response in the low FODMAP diet arm and a 46% response in the standard dietary advice arm. The next study that also used the NICE guidelines as their comparative intervention was conducted in the States, and this what this showed to us, similar to the previous study, is that there was no difference. If you focus where I put this yellow panel, firstly, there was no differences between the reports of feeling adequately relieved in terms of their symptom response, but they did show a significant difference in those who responded to the gastrointestinal pain. At the moment, as I said, most of the studies that have been conducted have been for under 6 weeks as an intervention phase. The data that we have at the moment showing efficacy of the low FODMAP diet in the long term comes from mostly retrospective trials. This one, which was done in Australia, showed that calling back patients who had been previously instructed by a dietitian on the low FODMAP diet at a median of 14 to 16-month follow-up, that they still were maintaining those who were still adherent and maintaining at least a modified FODMAP diet, that there was clinical benefit in up to 74% of these patients. When we follow the low FODMAP diet, because we're restricting the fructooligosaccharides and galactooligosaccharides, and when we're following the low FODMAP diet, we often are reducing these oligosaccharides by at least 50%. Now, these oligosaccharides are actually natural prebiotics for us, so therefore it's likely that a potential hazard of following the low FODMAP diet could be the effects on the GI microbiota. Now, in the last few years, because of this, it's really nice that most studies now are collecting or analysing for these effects. So this is just a snapshot of the 6 key studies that have now, using a variety of different methods or techniques and a variety of trial designs, have shown us results on the microbiota and metabolites. The first study that I'm going to show to you came from the King's College study. So they showed that after 4 weeks of following the low FODMAP diet, that there was a decrease in bifidobacteria count and abundance. This same group conducted another trial, which was published last year, and they showed again and confirmed their first results, that following the low FODMAP diet resulted in a lower bifidobacteria count. The study that I showed you from the Monash University group also collected their the fecal samples and analysed and found that there was reduced butyrate-producing bacteria and increased mucus-consuming bacteria. The Canadian group showed that following a high FODMAP diet also results in alterations in the metabolome in comparison to their baseline results. At the moment, because these studies have only been conducted short term, we don't understand whether there are any downstream effects to these microbiota results or changes, and we don't understand yet whether this will have consequences in either the short or long-term health outcomes. What we do know, however, from this study, which was published last year from the Bergen group in Norway, they showed us that the reintroduction phase, which is a key part of the implementation clinically of following the low FODMAP diet, that when we start to reintroduce the FODMAPs to a level that you tolerate, it may help us restore that bacteria change. So this study in 20 patients with diarrhea-dominant IBS at baseline were instructed to follow a low FODMAP diet, and you can see here, similar to the previous studies that I've already shown you, that there was a decrease in bifidobacteria. Yet after 10 days of having 16 grams of a fructooligosaccharides supplementation, that this bacteria recovered and actually recovered to an extent that was higher than their baseline level. One of the things that we are currently missing with the low FODMAP diet, especially given that it can be a complex diet to teach and takes time as a dietitian to teach the patient, is being able to predict who is going to clinically respond to the low FODMAP diet. 2 years ago, a group from Houston showed us that perhaps our baseline microbiome is a nice way, it can be a way of clinically responding. So this study that they published in AP&T showed us in children who had IBS that they were the ones that responded to the low FODMAP diet. This was very small numbers and it was only a very short-term intervention phase. So earlier this year, the Sweden group did a large amount of really nice analysis on the data from that previous trial where I showed you the low FODMAP diet versus the NICE guidelines. And what they did here is you can see that for the low FODMAP diet, if we look at who was more likely to not respond to the low FODMAP diet, that it could be predicted by having a higher dysbiosis index. Furthermore, they then went on to conduct a further analysis and are now able to give us hopefully some type of, or at least a snapshot of some bacterial targets for what we might be able to use later on in who's going to respond to the low FODMAP diet. Another potential hazard, seeing as though, as is the case with any dietary intervention or exclusion diet, is that we need to be aware of nutritional adequacy. So many of the studies now are also doing a lot more comprehensive macro and micronutrient analysis. This first study that I show you is from the same Sweden study, and you can see here that firstly for the low FODMAP diet that there was differences in all of the macronutrients, but however, for energy, protein and fat, that they also had lower amounts after following the NICE guidelines. Was only for the carbohydrates and fibre, which was lower, which is not to be surprising, seeing as though low FODMAP diet is obviously carbohydrate, and therefore if we're avoiding or restricting some of our grains, that we might be restricting high fibre containing grains. So this is important when it comes from a clinical perspective for us to remember and highlight to our patients which are the higher fibre containing low FODMAP grains. From the King's College group, they have done some micronutrient analysis and shows that the only micronutrients when following a low FODMAP diet in comparison to their habitual diet were calcium and iron. Calcium also is not to be surprised at, seeing as though we're restricting the lactose in a lot of our dairy foods. However, the problem with a large amount of nutritional analysis is the missing data in terms of products and whether this is accurate. What we do need to remember again from a clinical perspective is that we would then need to watch these for nutrient deficiencies when dealing with our patients. In terms of acceptability, seeing as though the low FODMAP diet is becoming increasingly popular and popular around the world, and many patients are not only seeing a health practitioner but also teaching themselves about the diet, we need to understand whether it's acceptable and is it acceptable in the long term. So this study, which was a retrospective analysis of up to 6 to 18 month follow-up of patients who had clinically been taught the low FODMAP diet or instructed. They asked them whether they were still feeling adequately controlled in their symptoms. They also did a nutritional adequacy using a basic food frequency questionnaire. But the key thing of finding that I would like to highlight from this study is that they asked these patients, were they still following a strict FODMAP diet? And if not, what were they mostly restricting? So if we were to follow a modified FODMAP diet in the long term, what do most patients blame? And it was the fructans and fructose groups that most of these patients who said that they were still symptomatically controlled, that they were avoiding most of the time. So fructans being the onion, garlic, wheat and rye, and fructose being the fruits, being apples and pears and mango. So in terms of clinically implementing the low FODMAP diet, I hope I've highlighted that it should be dietitian-delivered. I know that's not always easy given that dietitians are not always available in different clinical practices, but having a dietitian on board allows us to educate on the FODMAP principles, the food composition, ways to then follow the low FODMAP diet nutritionally adequately, and give our patients tips. This study that I'd like to highlight that just came out last month in the American Journal of Gastroenterology from the Monash University group highlighted that we are able to perhaps use the alpha-galactosidase enzyme to help us digest the galacto-oligosaccharides, knowing that those are one of the key FODMAPs that people will often avoid long term. So the steps that we normally follow when clinically implementing the low FODMAP diet is phase 1, instruct our patients to follow a low FODMAP diet for 4 to 8 weeks. We know from the studies if they follow that strictly that they will feel benefit within that first week. If they have felt symptom benefit, then re-challenge and loosen the diet according to their tolerance, knowing that each patient will have a different tolerance level to each of the FODMAP groups. Obviously, if they've been adherent and they've had no response, then abandon the diet or look at alternative therapies. The Monash University group have a FODMAP app in terms of being kept up to date with all of the latest foods being tested, and the app that they have developed is trying to establish, firstly, a global database, knowing that most of the evidence originally came from Australia. And these references down here are the food composition original articles that were published to analyse foods for their FODMAP contents. In terms of future research, obviously most of the data that exists at the moment has been conducted in the irritable bowel syndrome patients. What we now would like to do is move into other clinical conditions, particularly coexistent functional gut symptoms in IBD, which we have at the moment some hints that the low FODMAP diet will help. So this study, which was a retrospective study in 80 patients, showed that, or 88 IBD patients, showed that there was satisfactory of functional gut symptoms in these patients when following the low FODMAP diet. Another condition that has just been published 2 months ago was in 18 breastfeeding mothers who had clinically diagnosed infantile colic patients, and what they did here was they provided all of the mothers with, it was an open study, so not blinded, and what they did was they provided their mothers with 1 week of the low FODMAP diet and asked them to record according to measured and validated colic methods, and they found significant improvement in their crying and other colic-related symptoms. So this, although an open study and a small number, shows that perhaps there is something that might be happening also for colic babies. The next area, of course, is upper GI, knowing that a lot of the data is IBS being lower in the GI tract. So in Leuven, we have just finished a study where we used high resolution manometry, gastric manometry, to measure intragastric pressure to have an understanding of what was happening with the FODMAPs in the IBS group. So in this study, we recruited 20 healthy volunteers and 20 IBS patients, and we gave these patients an intragastric infusion of either the fructans or glucose. And what you can see here is the solid lines are the healthy controls, so they had a lower gastric or less of a gastric accommodation. And for both groups, the maroon, which is the fructan arm, over time the maroon arm had less accommodation in comparison to the glucose for both groups. Also in this study, knowing that the connection with the brain-gut axis, we asked our patients throughout the study days to fill in a series of psychological related questionnaires. This one is the STI and shows you the state anxiety. Firstly, you can see, as we have already known, that the IBS groups have higher baseline anxiety levels. However, when we then gave them the fructan challenge then significantly increased their anxiety levels. So in terms of understanding the mechanism behind those upper GI and psychological results, we're sort of questioning now or wanting to understand whether there is more of a neural or hormonal mechanism for underlying this increased hypersensitivity to these FODMAP effects. For other research, we've focused mostly on the fermentation and the gas production and the the high osmolarity or high osmotic activity of these FODMAPs. So whether there are other potential mechanisms that these FODMAPs might be affecting. So measuring transit time, looking at serotonin cell density or lipopolysaccharide in the stool to understand perhaps whether that can help us point to or differentiate the hypersensitivity. Ideally, we need to now identify and more clearly or carefully characterize our patients to understand the phenotypes of who's going to respond. And this is really where the microbiota might be a really nice clue to start with. The long-term dietary manipulation on the nutrient intake is always a question in any exclusion diet, and the only way to properly understand and measure this would be to do much larger trials with larger numbers and evaluate the nutrient intake at more sequential periods across the time. The GI microbiota obviously is the biggest thing at the moment in the low FODMAP diet concerns, but we don't know what consequences this has in terms of functional or health, both short-term and long-term. We also don't understand many other things in terms of whether it's going to affect or the changes that we are now seeing in the microbiome, whether it's going to have changes on the metabolic output, other measures of colonic health, the mucosal compartment, whether it affects the short-chain fatty acid concentrations. So in the future, we would like to move into in vitro studies, more look closely at this reintroduction phase and how we can really iron out the creases of the low FODMAP diet at the moment. And from the Bergen group and also a recent study from the King's College, whether we can supplement the low FODMAP diet with pro or prebiotics to prevent any of these detrimental changes from occurring. Lastly, implementation methods, because most of these studies at the moment have been done from a dietitian-taught basis. So we would like to understand whether the clinical improvement that we see from being taught by a dietitian, could this be still received by other ways, such as group education? And many of these things are more highlighted and discussed in a recent review that was published in June. So in my final slide, I would just like to finish with the one take-home message: the low FODMAP diet is now a proven, efficacious dietary approach, effective in 50 to 80% of IBS patients. And we know that the microbiota and its metabolites are affected, but we really need further research to clarify the clinical relevance of these changes. The gut microbiome composition at the moment is a likely potential biomarker for us to be able to identify the clinical responders. Finally, I'd like to thank the organisers for inviting me, and thank you all for your attention.